Chapter 13, the spinal cord and spinal nerves. The purpose of this chapter is to identify and describe the anatomical features of the spinal cord and spinal nerves, discuss the functions of the spinal cord and spinal nerves, and understand how they help maintain homeostasis in the body, and to understand spinal reflex arcs. The spinal cord and the spinal nerves will mediate reactions to environmental changes. The spinal cord has several functions, including processing reflexes. It is also the site for integration of excitatory postsynaptic potentials, or EPSPSs, and inhibitory postsynaptic potentials, IPSPs, that arise locally or that are triggered by nerve impulses from the periphery and the brain. Lastly, the spinal cord and spinal nerves are a conduction pathway for sensory impulses to the brain and motor impulses to effectors. What is another term that we can use when we discuss our sensory impulses or our motor impulses in the direction that those can be conveyed? All right, the spinal cord itself is protected by connective tissue coverings, meninges, vertebrae, and a cushion of cerebrospinal fluid. So here we see the vertebral column providing a bony protective covering. Of the spinal cord, we also see the meninges. The meninges are protective, and there are 3 connective tissue coverings that run continuously around the spinal cord and the brain. The outermost layer is the dura mater. The middle layer is the arachnoid, and the innermost layer is the pia mater. So here we see these layers actually peeled back and open for us. So the dura mater, the outer, the arachnoid, or the middle, and then finally we have the pia mater as the innermost layer here. Between each layer is a space, the subdural space, the subarachnoid space, and this subarachnoid space carries the cerebrospinal fluid, which provides a fluid protection barrier, and we'll have more details about that later. That's where a spinal tap is done to withdraw cerebrospinal fluid for diagnostic purposes. And then there are denticulate ligaments that are thickenings of the pia mater, and these denticulate ligaments suspend the spinal cord in the middle of the dural sheath. The spinal cord will begin as a continuation of the medulla oblongata, and it will terminate at about the level of the second lumbar vertebrae in the adult. So it will begin as a continuation of the medulla oblongata. It starts at the level of the foramen ovale, the foramen magnum. So the foramen magnum is where it begins, and then it will end at around L2. It contains cervical and lumbar enlargement. So here we see the lumbar enlargement and the cervical enlargement. The tapered portion of the spinal cord is called the conus medullaris. And from this conus medullaris, we will have our filum terminale and our cauda equinum arise. The internal anatomy of the spinal cord is divided into the white matter and the gray matter. The anterior median fissure and the posterior median sulcus will penetrate the white matter of the spinal cord and divide it into the right and the left side. Turn on our highlighter here. So here the anterior median fissure and the posterior median sulcus. The white matter will consist of bundles of myelinated axons of both motor and sensory neurons. It is white because the myelination gives it that color. The white matter is also divided into what we call columns. So here is a posterior white column. Here is an anterior white column. And each column will contain distinct bundles of nerve axons that have a common origin or destination and carry similar information. These bundles are called tracts. And so then we have sensory tracts, or sensory means that it goes towards the central nervous system. So ascending tracts conducting the impulses towards the brain. And our motor tracts then would be our descending tracts conducting the impulses down the cord. And then the gray matter. The gray matter of the spinal cord is shaped like the letter. Let me get our marker back. Is shaped like the letter H or butterfly shaped. In the center of the gray commissure is the central canal here. And it will run the entire length of the spinal cord, and it contains cerebral spinal fluid. Anterior to the gray commissure is the anterior white commissure, which connects the white matter of the right and the left sides of the spinal cord. The gray matter is divided into horns. And these horns contain cell bodies of neurons. The internal organization of the spinal cord allows for reflexes to be processed and to inform the brain of the results of those reflexes. We will discuss in more detail later in this chapter about reflexes. Spinal nerves. Spinal nerves connect the central nervous system to sensory receptors, muscles, and glands, and are a part of the peripheral nervous system. There are 31 pairs of spinal nerves, and they are named and numbered according to the region and the level of the spinal cord from which they emerge. So, the 31 pairs of spinal nerves include 8 pairs of cervical nerves, 12 pairs of thoracic spinal nerves, 5 pairs of lumbar spinal nerves, another 5 pairs of sacral spinal nerves, and finally 1 pair of coccygeal spinal nerves. Spinal nerves are the paths of communication between the spinal cord and most of the body. Roots are the 2 points of attachment, so an anterior and a posterior root that attach a spinal nerve to a segment of the spinal cord. Another word that we can use for anterior and posterior, given that our spinal cord is near our back, would be ventral and dorsal. So ventral would of course be your anterior side and dorsal would be your posterior. So you'll see oftentimes the dorsal root being used. And so the posterior or the dorsal sensory root, it contains sensory nerve fibers and will conduct nerve impulses from the periphery into the spinal cord. The posterior root ganglion contains the cell bodies of the sensory neurons from the periphery. The anterior or ventral motor root So here, the anterior. It contains motor neuron axons and conducts impulses from the spinal cord to the periphery. The cell bodies of motor neurons are located in the gray matter of the cord. All right, now back to the connective tissue coverings of the nerves. The spinal nerve axons are grouped within connective tissue sheaths. The names and prefixes of these sheaths should sound familiar. You can think back to our discussion on muscle fibers. A fiber is a single axon with an endoneurium. That endoneurium surrounds each axon. Then a fascicle is a bundle of fibers surrounded by the perineurium. And then finally, we have a bundle of fascicles all surrounded by the epineurium. So, as I mentioned, endoneurium, perineurium, epineurium, these should all sound very familiar to when we were talking about the muscle fibers. There are numerous blood vessels within the coverings. Shortly after the spinal nerve passes through its intervertebral foramen, a spinal nerve will divide into several branches. These branches are known as rami. Branches of a spinal nerve include the dorsal ramus, ventral ramus, meningeal branch, and rami communicans. The anterior rami of spinal nerves T2 through T12, so all of the thoracic nerves excluding thoracic nerve 1, do not enter into the formation of plexuses and are known as intercostal or thoracic nerves. These nerves will directly innervate structures they supply in the intercostal spaces. Their posterior rami, so T2 through T12, supplies the deep back muscles and the skin of the posterior aspect of your thorax. The ventral rami of spinal nerves, except for T2 through T12 again, forms networks of nerves called plexuses. So, we will be going more into detail about these plexuses. But remember, spinal nerves T2 through T12 do not form plexuses, and they will directly innervate the structures that they supply in the intercostal spaces. Dermatomes are segments of skin that are supplied by spinal nerves that carry somatic sensory nerve impulses to the brain. You do not need to memorize this image or this chart, but you do need to be able to interpret this mapping. If we say that there has been damage to thoracic nerve 1, you would then be able to say that loss of somatic sensory impulses would happen in the medial aspect of the upper limb. All right, the plexuses. So I would like to start by saying that you do not need to know the name of all of the nerves branching off of these plexuses. What we will talk about with the plexus is what it supplies. So you do need to know the areas that the plexus supplies. And you also need to know any nerves that we actually mention as far as damage or abnormalities, or any need to know information about specific nerves mentioned here. All right. The cervical plexus supplies the skin and the muscles of the head, neck, and upper part of the shoulders. It connects with some cranial nerves and supplies the diaphragm as well. The nerves bear names that are often descriptive of general regions that they supply or the course they take in emerging from the plexuses. Damage to the spinal cord above the origin of your phrenic nerve above the origin of the phrenic nerve, so that would be C3 to C5. So any damage above this region can lead to respiratory arrest. Breathing will stop because the phrenic nerve no longer sends impulses to your diaphragm. The brachial plexus constitutes the nerve supply for the upper extremities and a number of neck and shoulder muscles. A number of nerve disorders may result from injury to the brachial plexus. So among these injuries here, we are showing Erb-Duchenne palsy, or Waiter's tip, where the wrist curves in a hyperextension. This is also known as Waiter's tip palsy. Ulnar and radial injuries also occur here. Or wrist drop, claw hand, and winged scapula. So as you can see, because of nerve disorders or nerve function, the wrist is not able to basically stay at its normal orientation, or the grip of the fingers changes because of the nerve supply as well. And then winging of the scapula, if you look closely here, we'll see that the right scapula here has protruded in towards the midline or towards the median aspect. The lumbar plexus supplies the anterolateral abdominal wall, external genitals, and part of the lower extremities. The largest nerve arising from the lumbar plexus is your femoral nerve. And so injury to the femoral nerve is indicated by the inability to extend your leg and also by loss of sensation in the skin over the anterior medial aspect of the thigh. This would be something that we would be able to see using our dermatomes, that where if this area of the sensation loss over the period of the thigh would also coincide with our femoral nerve. Also, the obturator nerve. Injury here is a common complication of childbirth and results in paralysis of your ADD adductor muscles of the leg and loss of sensation over the medial aspect of the thigh. So, for example, my background is veterinary medicine again. So, in your quadruped animals, especially your cows who give birth standing to a larger birth weight offspring, the obturator nerve injury can be very common, and because those adductor muscles are affected, the mom is actually no longer able to stand and becomes has a period of paralysis where her legs are splayed out on the floor, and those back legs actually are out, and she's not able to bring them in to hold herself to stand anymore. Finally, the sacral plexus. The sacral plexus supplies the buttocks, perineum, and part of your lower extremities. The largest nerve arising from the sacral plexus and the largest nerve in the body, and probably one of the more common nerves we hear of as having nerve problems, is the sciatic nerve. The sciatic nerve, injury to the sciatic nerve, especially the common perineal portion and its branches, will result in what we call sciatica. This is a pain that extends from the buttock down the back of the leg. Often, sciatic nerve injury can occur due to a herniated or a slipped disc, dislocated hip, osteoarthritis of the lumbosacral spine, or pressure from the uterus during pregnancy, or an improperly administered gluteal injection. All right, we will pause at this point. This will be the end of the first part of your Chapter 13 lecture presentation.